So, good morning, good afternoon, good evening, wherever you are, and welcome to the continuous Ifso series of COVID webinars. Today is a special topic, and we're going to discuss training during the pandemic. And we have a great esteemed panel, our president, Dr. Lilian Cao, and Dr. Kelvin Higa needs no introduction. And we have a great panel as well, great presenters. Dr. Carl Miller and Dr. Abdurrahman Numeri and Dr. Julian Varos. And to get the to see how everyone is doing during this pandemic, let's initiate and start the first poll. Do you currently work in a training program? Please select one of the following options. And I'll go to Dr. Cao and Dr. Higa. And I know you've been training residents and fellows for a long time. How did you start the process, and what made you pursue it? Dr. Cao?
Question you asked is, how did I start being a bariatric surgeon, or how did I start working in the training program? Training residents or training myself?
Training residents.
Right. So I'm fortunate enough to work in a university hospital, and therefore bariatric surgery was always been a program even before I started. And so when I became a consultant, trainees came to us for bariatric training. So we didn't have to advertise too much. People came to us because the institution I worked with had a long tradition in bariatric surgery.
And I know, Dr. Higa, you've been in private practice for quite a while, but you're still motivated to train residents. How so? And fellows?
Yeah, actually, I've never wanted to train residents and fellows. It's really all of Dr. Numeri's fault. When he was, we were working together. He was part of the university training program, and we did a few cases together. And he planted the seed, this idea that totally changed my life. And I think that it's been a great journey. You know, when you're in private practice, you're doing case after case. It's quite rewarding in some ways, but it's somewhat empty in others. And if you never pass on some knowledge, some skills, and especially if you never have a chance to pick on the fellows and residents and harass them a little bit, you know, it's a great part of your life. So I'll have to thank Dr. Numeri for all of that.
Great. Can we see the results? So we have majority, 33%, they train residents and fellows as well. So let's move to the next poll and see what everybody did during the pandemic. So during the pandemic, what are the tools that you use to maintain your training program? And what did you do, Dr. Cao, during this time?
Well, we had a shutdown of all elective surgery, including bariatric surgery, so we couldn't do any of this. But with our fellows and residents, we could do emergency surgery, and we used the time to update what we were lacking, update our protocols, and that was really very helpful.
Great. And what about you, Dr. Higa?
Ditto. You know, in some ways, the practice is so busy that we don't really have a lot of time to work on some of the finer points of medicine. Certainly in the operating room is always where everyone wants to be, but in the clinic and the office, it's difficult to see what each fellow is doing with every patient. So now that we're doing a lot of telemedicine and we're sort of sitting next to each other and in close proximity, we can hear each other talk. It's been a really great experience. I can see how they interact with patients. They can see how I interact, and we have a chance to actually discuss patients in more detail in between. So I think it's been a real unexpected bonus toward the end of a fellowship. Of course, the fellows, this is the time when they really want to blossom and start to work and doing cases, but you know, that'll come with time.
So unfortunately, 52% said they stopped completely, while it's a variety of what to do next. And it's good that 12% actually personally supervised practice on simulators, which is a good thing. So we're going to have our first presenter, Dr. Abdurrahman Numairi, present about deliberate practice, but let's see what the audience think of deliberate practice with launching the third poll. And what is deliberate practice to you? And I know probably all of us heard about it, and it's been a discussion between peak and outliers. Do you do deliberate practice or just practice? Is it 10,000 hours to become an expert? So what do you think, Dr. Cal? What is deliberate practice to you?
I think particularly with the pandemic, which was challenging and unprecedented, we really didn't know how to do things. We learned how to, particularly in our practice, patients didn't want to come and see us, and yet they needed to see us. So in my practice, we learned to do telemedicine. We used to do phone consults to help our patients get through. And what we also found was that not only they wanted contact with the surgeons, they also wanted contact with the rest of the multidisciplinary team. So the whole team had to learn to continue to provide consultations to our patients, but in a different form.
Well, that's good. And what about you, Dr. Higa? Are you a 10,000 hour or just deliberate practice?
Oh.
And
Well, it's a little of both. You know, I used the video recording on videotape at the time to review cases, to really just hone down techniques, see what was efficient, not efficient, what wasn't working, and really it's quite interesting to be able to, even like I said, I was sitting with my grandson, we were watching the AIS channel before a esophagectomy, just picking up hints and looking at different things, how to make things better, and always changing. But I'm a slow learner, so it probably takes me like 20,000 hours to get something done. But it's always been a great interest to me because, you know, with 1 year per fellow, it's almost like not enough time, and the better we can teach without all the pain involved, I think is great.
so, Dr. Mary, how did the audience do?
I think they've done very well. They're pretty close, and the fact that there is diversity in the answers tells me that the lecture is warranted.
Yes, I think so too. So please go ahead.
Pretty necessary.
Sure. So if you give me the presenter privilege, I will launch my slides. Thank you. So thank you, Ahmed, for the invitation to discuss this topic. And thank you, Lillian, as well, and Kelvin for the kind comments. It was really my privilege to been able to work with Kelvin for several years, and I've learned from him most of what I know about bariatric surgery today. So this is my disclosure slide next, and it has no bearing on the presentation, but I think we try in the communication committee at Ifso to have surgeons present their own cases that they've done in their lifetime. This shows bias towards different procedures. So when you look at these people in the picture, and I think being Kelvin's partner in the past, his junior partner, I think I have the privilege of embarrassing him a little bit. You could say that these people are genius. I think at the turn of the century, Einstein was, the icon of being genius. We can see many people that you can see here that are genius. And historically, there have been books written about genius and having natural abilities. And this was the way it was touted. So if someone is genius, is because this is something they were born with. And the first time I read about a deliberate practice from Professor Anders Ericsson in Florida, who's a professor and an expert in the science of expertise, and this is one of his books called Peak, it really interested me. So I'm going to show you the first study he did first about deliberate practice, which is the West Berlin violin student study, very similar to a Swedish obesity study that's very well published in bariatric surgery. So what they did is they wanted to see could they know who is the best music or violin player, and they picked 30 students that were matched for gender and age, and they wanted to compare those 30 students to 10 of the best violin players in West Berlin. So they chose 10 students by professors from an elite school. They chose 10 who were considered to be average, and they chose 10 that were the worst expected, but they didn't call them the worst expected. They called them the music teachers, who will probably be teaching music in high schools across Germany. And they wanted to compare these to 10 accomplished violinists in one of the most prestigious orchestras in West Berlin. And this study was published in 1993. And they obtained data looking at extensive diaries, looking at when did you start playing, how often did you play, did you participate in competitions, did you keep a diary of how often you played. And they asked people specific tips that would matter to someone who plays the violin. How do you hold the violin? How do you use your hand, your fingers, things that objective. And then finally, they asked people if it was fun to practice, and they wanted to see if grit had to do with people continuing. So what they found was, obviously, you have more leisure time on the weekend. That validates what we all know. But what they found was the earlier you start, the more chance you have to become one of those 10 best students. They found that the 10 best students started way, way early. Before we started, Kelvin was telling us about his grandchild that was watching videos with him at the AIS channel. So I think, Kelvin, you're on the right track. But then they also found that the best students kept diaries that matched the 6-week period that were included in the study, much more than the music teachers, the worst students, or the good students. They also found that over time, when people reach an age of 20, they have accumulated 10,000 hours. And Malcolm Gladwell has popularized this 10,000 hour rule, but Anders Ericsson in his book talks about the fact that it's not about the hours, it's about the quality of time spent practicing. And they found that you could actually differentiate the best from the worst just by looking at the hours played, and the hours of the best students matched those professionals by the time they were 20. So let me give you an example. So someone runs every week, they run 5 days a week, and they run 5 miles every time, but they don't have anybody to help them. They could keep running, but they don't improve over time. So the idea of deliberate practice is working outside of your comfort zone with specific goals, having a coach who not only knows what they're talking about, but they can detect when you're not doing well and where you're not doing well, and then developing mental models of what you're trying to achieve. I'll give you an example. So if someone gives you a small, you never played golf, and they give you 100 golf balls and they let you start putting in the office, by the time you reach the 50th, 60 or 70 balls, you're pretty close and you've developed some muscle memory. But if we block that hole, you will not improve because there's no feedback. So feedback is one of the most important things in deliberate practice. The second thing is the feedback has to be objective. It cannot be subjective. It has to be done by an experienced coach who knows exactly when you make mistakes and can point them out. The coach has to give you specific tasks to do, and you have to spend time on your own honing those tasks. And you have to work in an educational environment. This is extremely important. Negative reinforcement tends not to work well, and the whole process has to be deliberate, goal-oriented, and outside one's comfort zone. So let's talk about competence. So there are 4 stages of competence, and most of you know them. So initially, when you start, if you ask your 3-year-old, can you drive the car? They will tell you absolutely. Their feet can't reach the gas pedal, but they think they can drive the car. They're incompetent, but they're unconscious about it. If you ask your 9-year-old, can you drive the car? They will tell you no. I'll probably kill everyone, because they're conscious about their incompetence. While if you ask your 16-year-old who just got their driver's license with their hands both firmly on the steering wheel, they'll tell you, could you please not talk to me? They're very conscious about their competence, and we text and drive. So in surgery, we're the most dangerous when we are in the 4th stage. So what does this have to do about training or bariatric surgery? The training models has been teach one, see one, do one, and teach one. And people do too many, not just one, and they watch a lot. When they get to do something, there's not a lot of critical thinking, and there's maybe a lot of yelling and screaming in many places. At least they were when I was a resident, and that's not very helpful. Look at the numbers of bariatric surgeries, and most of you know this graph. Let's look at Roux-en-Y gastric bypass. Why is it dropping? Is it because it's not effective? Is it high risk? Or is it because it has a very high, steep learning curve? I mean, I will contend to you that creation and closure of the jejuno-jejunostomy and creating a small pouch that is tension-free are the reasons this procedure is going by the wayside. So if you compare to one anastomosis gastric bypass to Roux-en-Y gastric bypass, it's like comparing a scooter, a skateboard, and a ripstick. And if you have kids who've used these, I certainly have not had the privilege of using them. When you do sleeve gastrectomy, you do not do any anastomosis, and you only work above the colon, which is easier. And if you do one anastomosis gastric bypass, you do one anastomosis and you work above the colon, and most surgeons don't close it. But if you do Roux-en-Y gastric bypass, you need to do one anastomosis above, one below the colon. You need to make a short pouch, and you need to close 2 mesenteric defects. So the learning curve is very different. So when you compare these procedures, you cannot compare them and expect the same outcomes. And if we learn from history, colorectal surgery in 2004, the COST trial showed that laparoscopic colectomy is equivalent to open colectomy. But until 2012, and even now, only a third of colectomies are done laparoscopically. So when you create an anastomosis below the colon, like the JJ, port placement creates an important factor with the way you stand. Intracorporeal suturing involves using your non-dominant hand, involves depth perception. If you don't have the ports right, it becomes difficult. Closing the spaces is another area of difficulty. Doing anticolic versus retrocolic is another area of difficulty. Super obesity makes the case difficult, as surgeons put their ports based on surface anatomy, and the inside anatomy changes. And if you look at, for instance, the important study about internal hernia, the landmark study published in 2016, if you look at internal hernias in green and obstruction, over time, if you close the defect, it's lower. But initially, there was higher incidence of obstructions at the JJ because of learning curve. So what's the solution? I contend it is not robotic surgery. And I think the solution is to have deliberate practice involved in our environment. Having focused deliberate practice, feedback that is objective with a coach, you working on your own, specific goals in an educational environment outside someone's comfort zone, what I showed you earlier. And let's just, for the sake of showing you this, I'm going to explain to you a couple of things that have to do with gastric bypass and JJ. First is port placement. If you put ports based on surface anatomy, you'll have difficulty. I learned this from Kelvin. He puts his first port in the left up quadrant. The moment I saw this, I realized that I'm looking at something very, very unique. And you need to put your camera port based on the inside. In open surgery, we're very dogmatic about where we put our incisions. They even have names: Coker's incision, McBurney's. but surgeons come to do laparoscopy, they throw the ports anywhere and expect the surgery to work. So you need to look at on the inside and decide where to put your ports based on inside anatomy. The second thing is you have to teach trainees that the free needle could be held in different positions. It could be pointing towards 9 o'clock like the top, or 7 o'clock like the bottom. The third thing is when you create and join two pieces of bowels together with the mesentery in the bottom and the bowels look like this, you cannot put the first stitch at the anti-mesenteric border because you have very little real estate to work with. You have to put the first stitch between 3 o'clock and 9 o'clock to have more real estate. This is something you do not want to describe in the OR. You want to talk about this outside the OR so the person has a mental model about it. In addition, when someone does a stapled anastomosis, I ask the residents, how does it look like? And they tell me it looks like a circle. The reality is it doesn't. The place where the cartridge was is larger than the place where the anvil was. And this is important because if you think it looks like a circle and you just put bites like this, that's what should happen. The fact is, if you do that, you will end up with a dog ear every single time. So when you put your sutures, you need to take wide bites between 12 o'clock and 6 o'clock and narrow bites between 6 o'clock and 12 o'clock. And this is something you have to teach residents outside the OR so they can do it inside the OR, so you don't have a dog ear at the end. So for looking at it in a very short video, you don't put the first stitch at the anti-mesenteric border. So you should talk about this with them before. You put it near the mesenteric border at 3 o'clock and 9 o'clock. And once you do that, then where you put the enterotomy becomes easier, the closure becomes easier. And when you put the stapler, wherever you put the cartridge, it's going to have a larger enterotomy than the other side. So that's where you should travel. So these are important things to discuss before the patient, the trainee rather, goes to the operating room. The other thing is when you take the sutures, you want to make sure you always grab underneath where the bite is going to go. You want to always follow the needle, and then use your non-dominant hand effectively to do your work. And then finally, let's look at closure of the jejuno-jejunostomy defect. I showed you earlier that in the randomized trial, there were more incidents of obstruction. What's important is to do a purse string closure and not to include the mesentery. So this is an area where I'll show you that the trainee is including the mesentery in the next bite. And we will talk about, no, this bite here is too close to the mesentery. So they have to back up and take it away from the mesentery. And these are the important tips that you need to talk to someone in the operating room. And the final thing is we are now looking at cumulative sum objective analysis. This is something that used to be done in industries other than surgery to see how many cases does it take someone to go from novice stage to becoming close to an expert. So deliberate practice is focused practice. And I think just like it's done in many places, when you think about bariatric surgery training, that's what you should think about. So the next time you see these guys, don't think that they're genius. Just know that they've done deliberate practice, not their genetic abilities are unbelievable. I'm going to stop there, and I want to thank you again for the opportunity to present.
Thank you very much, Abdurrahman. This is very interesting. Not the first time that I see it, but second time, but it gets more interesting. So how did the audience do? So you summarized deliberate practice. So it's focused practice with an expert feedback, right?
Right. So I think the 10,000 hours alone are not enough, because if the 10,000 hours are spent in an uneducational environment where there is very little autonomy, they might not be as effective. I think someone could actually get more in less hours, especially with the 80-hour work week, if there is work in simulation. What we do for our fellows is they first get to watch unedited videos of the procedure they're going to work. So every surgeon has their index operations unedited. After they watch that video, the next step is to go to the simulation lab, and we talk about the concepts of where to put the sutures when you create an anastomosis, how do you have to use your non-dominant hand, depth perception. Then you spend time with them in the simulation lab to show them where their errors are. Then they have to spend time on their own every week, at least for 3 hours in the first 6 months of the fellowship. And we found that to be very effective in improving people.
So nowadays there are, training programs, and we're trying to incorporate better models for practice. Dr. Higa, during I don't want to entail your age or your gray hair, but you somehow laparoscopic surgery was not the mainstay during your training, and although you became an expert at it. So how did you achieve it, and did you see deliberate practice within that time you trained yourself?
I wish it was better. I mean, it was the time of evolution when dinosaurs roamed the earth, as you kind of alluded to. It was developed after I came out, and it was all postgraduate training. We had some videos, and I was lucky enough and it's before the internet, so it was lucky enough to see some tapes of some really great surgeons do some things very easily. For example, and just anecdotally, I was struggling trying to do Nissens, and it would take me 2.5, 3 hours to do a Nissen, and I was hurting, my back was sore, and I saw a videotape of Butch Rosser doing a Nissen from the left side, sitting down, talking, very confident, and it reminded me, my father told me a long time ago, if it looks hard, you're doing something wrong. And from that point on, it was just a matter of trying to make things look easy all the time. So in a way, I wish I had the mentorship and the ability to reach out like we do today. The learning curve may have been a little bit shorter.
And Dr. Cal, now we have mentors, we have some people who train us. But as a trainer and somebody who trains, do you need to practice training others as well? And do you use deliberate practice within those tools?
I think it's very important when you train someone that you teach them how to be comfortable, because it's very easy for someone to come and watch an experienced surgeon operate, and you don't actually realize what that surgeon is doing. It looks too easy. Come and watch Dr. Higa operate. It looks so easy. I can go back and do the same thing. But truly, I mean, Dr. Higa, for what he's done, he has a set process. He's got his ports in the right place. He knows what to do. And I think that's very important, the trainee coming along, to just not watch something and say, that looks too easy and I can do it. You really need to take them step by step, and then they will learn the mistakes, they will learn through their difficulties, and then work on their weaknesses and try and improve on how they can get their technical skills better. And then that's very important. I think, not just how many you can do, is every operation, every procedure you do, you need to learn on it. And I think that's very important.
And Abdurrahman, I'll ask you this. A lot of people achieved great things without somebody else telling them what to do. And can you become an expert without expert feedback?
You could, but I think you'll have too many preventable complications in the process. And I think the goal in this time and age is patient safety. And I think having people, trainees in an environment like this saves patients and makes sure that the quality of care is high, make sure also that costs are low, and that makes our specialty very valuable. So we cannot afford anymore to having people come into the OR and practice there. I tell the fellows, if you come in the OR and you're still dropping the needle and can't load it right, it's not fair to you, it's not fair to me, it's not fair to the staff, and it's not fair to the patient. You need to spend your own time in the same lab learning how to load and unload the needle like we talked about. And I can tell every week if someone has spent their 3 hours in the same lab from last week compared to not. And it shows. And this actually has incentive. In deliberate practice, there is not only goal, but there is incentive. And the incentive I have is every fellow has an hour to sometimes an hour and 20 minutes to do the case. And if they do not progress well, I'm going to take over. And that's the incentive for the person to know that they need to do some work on their own.
Great. I forgot to introduce our fact checker. He's behind the scenes, always behind the scenes. Hopefully you'll see him next week discussing the journal club. Hazem, how did we do on deliberate practice? And do you have anything to add?
Good day, good evening, and good morning, good afternoon to everyone. Not much to add, to be honest. Thank you, Dr. Abdurrahman, for the nice presentation. I really enjoyed it. So if I may add one thing, deliberate practice is the hours, it's the quality, it's the being focused, being mentored. And the only thing to add to it is that it is a dynamic process. So at each stage of one's career or training, their needs for practice and their focus of the practice will change. And this is where the role of a mentor comes into play. You've quoted the models of athletes. I think this is the best example anyone can quote. A tennis player would need a certain trainer at one stage. Later on in their career, they need to move it on to a different level. The other thing I would need to add is the level of competency. And as you said, the most dangerous of people are those who are unconsciously competent. And what they found in experiments is that senior individuals are more prone to making mistakes and missing simple things because they go into their routine, into their comfort zone. And bit by bit, they start missing little details compared to a new joiner or a fresh pair of eyes. And this is the role of continuous education and repeated focus training to be utilized in the training of these individuals. But other than that, I've got nothing else to add. Thank you.
Thank you very much, Hazem. This was very insightful. And if we can launch the fourth poll, Manuela, before we introduce Julian. And so in your view, what is the most important element to training on advanced surgical skills? So please go ahead and answer. And I'm starting to see the questions coming along. Please type in your question in the question section and we'll get to them at the end of the discussion, hopefully after the presentations. And thank you. So Dr. Kao, what do you think is the most important element in training? Is it the expert feedback? Is it the hours that you put in practice? Videos, outcomes review?
I think they're all important, but if I had to pick the most important, I think structural feedback from a supervisor is the most important, because an expert watching you operate can tell you what you can or cannot do, what you're doing wrong, and you know, pick up on your technical skills.
Great. And Dr. Higa?
Yeah, I agree. I think they're all important. Maybe number 4 is the least. You know, feedback is always essential, and it's always appreciated. You know, as you know, I've reached out to a lot of you on the panel to even now to criticize, critique, and help me with, you know, to be a better surgeon, and certainly that's always been very much appreciated.
Great. Thank you. Let's close the poll and see what the audience think. And the audience actually agree that structured feedback from an expert mentor is the most important element. And with that, Julian Varas. Julian is somebody who helped us a lot in Ifso Dubai, Ifso Madrid. He and his team from Chile helped us establish the simulation and surgical academy during the Ifso Congress with their tool and their platform. So thank you very much, Julian, for being here, and please go ahead.
Thank you very much for that introduction, Ahmad, and also thank you, Dr. Nimeri, for that excellent first presentation. I think I'm going to try and complement that with what we're doing also very distant in the world from Chile. I'm going to talk about a platform for remote advanced surgical training. This is my disclosure slide. We know simulation works. It decreases human error to the minimum. And we just have to take a look to the aviation industry, where human error is, 3 out of 10 million people die on a plane crash. This is very little. What happens in surgery in our field? So learning is technically challenged, and with a prolonged learning curve, it is not easy to acquire the skills and the competency. As Dr. Nimeri said, you need deliberate practice and training. Now, if we add a small problem above this, such as coronavirus, it makes it much more difficult to have access to training. So to try and maintain skills and training process through the COVID-19 pandemic might be quite challenging. We need to start addressing some key issues, such as how can I establish a training program that can be immune even to this virus? We need a training program that has to be accessible all the time, all year, such as a gymnasium where you go and lift weight. We need a training program that has been demonstrated that you have effectiveness in real scenario. This means that when you train at simulation lab, then the skills will be transferred to the real scenario. We need a cost-effective training program that can be replicated anywhere. And what is really important, as Dr. Nimeri said, we need personal trainers to give feedback to all users at any time, and for them to start practicing with and deliberate practicing. So we need something that can be replicated anytime, anywhere, including pandemics. And also we need to start training advanced techniques, and not only to train basic skills, such as considering a program like an introduction to the patient. We need to be overtrained so that when you go to the patient will be easy. With this in mind, in order to establish any kind of simulation training program and a simulation center, we need basically 3 pillars. We need the hardware, of course, the simulator. We need a validated training program, and we need a teaching network of instructors. We need the teachers to give us feedback. So the first pillar is not that difficult to achieve. Most simulation centers have these bench models, and you can exactly do many kinds of exercise. But the training program is a must. If I want to show you, for example, one of our training programs we do in Chile is exactly what you're looking. You can do a lot of stitches, or you can, for example, create a bowel anastomosis. We can validate this if we measure all sessions. For example, what I'm showing you here is we have a complete learning curve of 16 sessions of an average of 1 or 2 hours every session, a group of trainees, first year junior trainees, that are very heterogenic, and they end up very homogenic and very good. Actually, over 20 points out of 25 is considered kind of an expert if you look from a global rating scales that have been validated, the OSAT's global rating scales. They become really quick, very fast. For example, at session 3, they are already very quick, but this doesn't mean that they are good, because if you see performance here, the quality of what they are doing, they're in the mid of their learning curve. So we need to train them more than 3 sessions. So we need, instead of intensive 2-day courses, 3-day courses, what we need is constant training and continuous training. We validated this training program, and we measured junior trainees at the operating room and compared them with general surgeons graduated from traditional programs of 5 years, 3 to 5 years. And these general surgeons had no simulation training. And as you can see, with 16 sessions of training, the worst trainee from a performance point of view, from a global rating scale point of view, had better rating compared to general surgeons without simulation training. So it was a must, since this experiment go on, that at least at our institution, everyone had to be trained. As you can see in this video, a program year 1 that is very trained, he has never done a stitch on a human patient, but now he has practice and had delivered practice with feedback on every session. And as you can see, this is the first time he performs a bowel anastomosis on a Roux-en-Y gastric bypass on a real patient, and he's performing really nice. So how can we take these three pillars anywhere? Is it possible to take advantage of the simulation centers that are out there? Well, Uber has done this with the cars that are everywhere and convert them, if you want, to a taxi driver and a taxi cab. What we did was we created a platform called C1 Do One in honor to Halstead. It was too long to name it C1 Do One Teach One, so we call it C1 Do One. And we created a course called Lab for Basic Lab and Advanced Lab. It works, you download the app, and now the student can watch a tutorial video, and he will go to a gymnasium. He will be able to perform what he thinks is right. The video will get now uploaded to a cloud. And once it's in the cloud, the good thing is that a teacher network of instructor, a teaching network now receives this video and can assess with feedback the video. This is in a deferred way. This is not a live video because it is like replying to an email. We know that the time of a teacher is really not easy to, it has a high opportunity cost. So usually a teacher with this system will have at least 72 hours to assess it. He can put pause, the teacher can put pause at any time and give a specific feedback, for example, an audio feedback, a drawing, a text, and also can assess using global and specific rating skills. So the video will go back now to the trainee, and the trainee will be able to watch all of the feedbacks. Usually we have between 15 to 20 feedbacks average on every video. He will be able to watch this video of his own mistakes and improve them and go back and train. This is a reality in Chile. We already have 6 centers in Chile distributed along the country, and also 1 in Lima, Peru. We soon will have in other countries. Does this work? Well, is it as good as in-person feedback? We demonstrated that in-person feedback, the control group, and with the lab system, both groups achieved over 20 points of scores, even if you are performing the practice with remote feedback. So it is as good as in-person feedback. The good thing about remote feedback is, as you can imagine, a lot of data is being harvested. And we now know, for example, that the last 10 months have accumulated over 10,000 feedback. So we can analyze this and start understanding what is a good feedback. Is it drawing? Is it a video, text, or audio? In what proportion? What are they saying? What is a good teacher? So the challenge now, how to maintain skills in the training process through COVID-19 pandemic. What we've done, as you can see here, we see junior trainees from our residency program. They're actually, they took bench models, they took the simulators to their residency, where usually they have protected time between ORs, or now with the pandemic, there's very few OR. So this is at the hospital. And with this kind of system, as you can see, they are wearing their masks and they're avoiding big crowds. We now have the network of instructors is giving remote expert feedback. And we are also having and continue having an average of 18 feedback per session. So we are enabling and the continuous training even through the pandemic. And I think the message here is that with technology, when we use it in our favor, we can actually adapt to crisis and we can take advantage of it. And our trainees must continue training. So I imagine a close future where these lights that are planes going from one side to another, that we can create this huge network of teachers that will be giving feedback to their trainees from one country to another. That's what I wanted to share. Thank you very much.
Thank you very much, Julian. Very interesting even to see it for the fourth or fifth time. It's a great platform. So one question for you that I want to show. So what can you do on this platform, and what are the techniques that you're implementing or making residents and fellows practice on these platforms? Can you describe the spectrum?
Yes. So the first thing is the limit is a unlimited creativity. The unlimited creativity can make you train whatever you desire. So nowadays we already have structured programs, and they are all validated. We have demonstrated that the skills are transferred to the OR. For basic curriculum, advanced curriculum, we also have HPB curriculum. We have a bariatric curriculum where you can train. For example, you start closing some diaphragm pillars, but then you go to train hand-sewn manual jejuno-jejunostomies and also gastro-jejunostomies. You can, after that, complete a complete procedure on these bench models. And then what we're having now, we're also evolving this to perfuse models. I think if you're overtrained, as I'm telling you, for example, if you are doing suturing, let's say an arterial anastomosis that is pumped with artificial blood, usually you will not have to do this on a patient, but if you're overtrained, when you go to a patient, it will be much more easy. So we're also taking our training to that level. We are training not only trainees, junior trainees, such as first year junior residents, we are training all kinds of levels. So also our fellowships and our staff members. For example, our experts in HPV train before they go and do a Whipple, a lap Whipple, for example. So this is a very motivating and encouraging example for our trainees, for them to go to the gymnasium and train.
So I'll go to the panelists, and Dr. Cao, how do you evaluate the progress of your trainees? What are the milestones that you look for? And do you use simulation as a tool to monitor their progress?
That's a very good question, because we don't have the tools that Julian has. And I wish we do have that kind of structured program in our country. But certainly we do assess their technical skills from the beginning of their training to the end of their training, and we do like to see a huge improvement. So technical skills is very important, speed is very important, safety is very important. So those are the things we look for.
Great, thank you. If we can launch the fifth poll just to see what the audience had access to during this pandemic. And meanwhile, I'll ask Dr. Higa, and what tools do you use to evaluate your fellows and residents?
Yeah, I wish we had a nice simulation system like we just saw. You know, it really requires quite a bit of resources to put this together, and special people to kind of man it, because we have to also, you can't just send someone off on a trainer without the oversight and things like this. For me, it's really about, it's almost more philosophical. When we get a resident or a new fellow, it's about more the fundamentals. Are we mastering the fundamentals, not the procedure? And for me, that's very important. If you understand the fundamentals, then you can apply it to any operation. But if you're more procedure specific, then you really can't grow. And so I spent a lot of time just on the fundamentals, and it's very frustrating, I think, for a lot of the trainees, because they really understand after 5 years of learning, they're ready to go out and start doing things. But with laparoscopy, it's a completely different set of skills.
I agree. So let's close the poll and see what the audience had. So during the pandemic, majority, 33% were restricted they consider training on laparoscopic simulators necessary. So training was halted. Only 8% had access to laparoscopic simulators. So thank you very much, Julian. Hazem, how did we do in this session? And if you have anything to add, please.
Not really to add other than congratulate Julian. This is the first time I see this presentation. It's an eye-opener. It's a model for others to follow. I congratulate him, but other than that, I don't think I could say much. Well done, Julian.
Thank you, Hazem.
Thank you very much.
So let's launch the last poll prior to Dr. Miller's important topic, which actually probably controls everything that we do, the mind. Do you or your training program work on mental training? And I'll ask Dr. Higa and Dr. Cow, do you incorporate mental training?
Do you want to start, Lillian?
I like to say we do, but I like to hear what Charlie Miller has to talk about mental training, and then I'll give my
That's an honest
conclusion.
answer. How about you, Dr. Higa? I know you incorporated very well.
Yeah, I think mental training is very important. It's essential, and it's a discipline that I think we don't spend much time on. And I'm really excited. I'm glad you included this as well, because it's really to prepare yourself for the unknown, to anticipate that unexpected, and to really plan out an operation from start to finish, every single step, in order to achieve perfection.
So only 1% thankfully do not consider it essential, and majority would like to include it, and 19% have it but not structured, while 15% have a structure to it. So Dr. Miller, I'd like to thank you for bringing the topic up and making us do a webinar on training, as it is important. So without further ado, please.
So I experienced a lot of interruptions during, and I hope it will work properly. So I would like to share my screen, and I would love to get the feedback if you can see my screen.
Yes, we can.
Yeah, great. Then I take away my picture here and remove this a little bit and start. Oh my God, this computer stuff, I get crazy.
No worries.
No, it will not open. I have no idea why.
Maybe if you try to go to view on top in the and launch it there, see if it works. View slideshow. Or in slideshow. Right. There you go. We can wait. Maybe try to relaunch the PowerPoint again and see if it works.
I think that might be the best option. I removed all my stuff from my computer so that I do not have any interference, and code even doesn't open. Let's see if I have this possibility here. No.
So meanwhile, let's try to get to some of the questions. And one of the interesting question that Dr. Ken Loy had is we do not work on surgical ergonomics is not well taught and documented in all specialties. Dr. Higa and Dr. Cao, do you talk about ergonomics with your fellows, and how do you approach it?
I think ergonomics is very important. I stress that with all my trainees is to work and make sure that they're comfortable with their hands, and also they're also comfortable in their positioning. Otherwise, at the end of an operation, they will have stiffness, they will have problems with their neck, they have problems with their wrists, and they won't be enjoying their operation. So ergonomics is very, very important, particularly in laparoscopic surgery and in robotic surgery as well.
And Dr. Higa?
Yeah, absolutely. Exactly what Lillian said. You know, I think that's one of the reasons why the robot is so popular is because, and it's not just with laparoscopy, but open surgery as well. We don't teach enough ergonomics and how do we protect ourselves for a long career. Neck injuries, back injuries, carpal tunnel, all these sort of things. I think it's really important that we teach young surgeons how they can sustain their craft for a lifetime.
So during bariatric cases, when you stand, just so we have an idea, do you stand in between the legs? Do you have a French position? How do you approach bariatric surgery, Dr. Cal?
I stand on the right-hand side of the patient.
You do. And Dr. Higa?
Yeah, I stand on the right side as well. I think it's important to know that, you know, everybody has a different height. Their arm lengths are different, and you know, putting in your trocars and your ports according to your own body is important to be able to do that. So you know, sometimes it's better to stand between the legs, or some people, sometimes on one side. But it's important, like what Dr. Nameri said. You know, when we're training, we have to be fluid enough to realize that there are differences, and that just because someone is doing something a certain way all the time doesn't mean it's the best way. And it takes somebody from the outside looking in to a coach to be able to say, you know, Tiger, you're not a very good golf player. I think we can change your swing and be better. And sometimes, you know, that's very helpful for all of us.
That's great. So
I agree. I think flexibility is very important. You know, they have to be flexible in their techniques. They just shouldn't just learn one technique and just stick to it. They should, you know, try different techniques.
Yeah, and it may be uncomfortable at first because it's abnormal. It's something that's you just, if you do something different, it's always uncomfortable at first, even though it might be the better way of doing it.
That's true, and we'll carry that discussion after Dr. Miller's presentation. We have the slides now. Dr. Miller, please go ahead.
No, now I'm unmuted. Super. I think it should work now, hopefully. So you can hear me, yes?
Yes, we can hear you and see the slides.
Great. So you already saw my disclosures, and I would like to emphasize and to continue. So mental training. What is your thought when you hear mental training? And if I ask my colleagues, most of them are telling me, okay, it's in sport essential, absolutely. If you are an athlete, you need to be very great in mastering mental training to be absolutely superior. So how our brain is working, and I have to tell you that we have two systems, and one system is that acts very fast, very impulsive, and automatic. And on the other hand, our second system is very thoughtful, very deliberating, and very focused. And I would appreciate if all other microphones and loudspeakers are on mute, because I get a lot of echo. So how would you predict the consequences of actions when you think on those two systems? And that is something where we start thinking on how do we program our subconsciousness, which is practically one of the systems. And Abdelrahman Nimeri really brought it very perfectly, how we program our mind, our mindset, where on the other hand, we have a critical factor that decides which program will be started when we have any action, any view outside, any signal that is coming from our planning, from our logical thinking, which program we start automatically. So that is absolutely crucial when it comes to anxiousness, when it comes to a situation where you are not trained, where you have to start making a decision. Before you start your program in your subconsciousness, or you reject this signal. And as you have heard already at the beginning, everything starts with unconsciousness incompetence, where you say, yes, I can do it, but you realize that is far away from that you can do it. Usually, the best example is when you learn driving a bicycle or driving a car, as Abdelrahman showed you, where you get the absolutely the consciousness incompetence experience, and you start programming your subconsciousness more and more, that processes are doing and going more automatically. So now you reach the phase where you got the conscious competence, until you get to the very dangerous part of unconsciousness competence, where you can use your telephone while you are driving, or when you drive, let's say you ask yourself 1 kilometer after a situation what happened in between, and you cannot even tell because you drive automatically. And most probably that's the most dangerous phase in our practice. So I start always with the question, what are the requirements people who are, let's say, high athletes in sport, in aviation, and also in surgery? What are the requirements? And they are all the same. We have high cognitive movements that we need to be mastered in a complex motion sequence, and also partly in extreme stress situations. So that is what we do have in common with these professionals. And on the other hand, we have to think about what do we or what do they have in common. So we have requirements, and on the other hand, there are things that we all have in common in our everyday life. And that is problems in family, problems with our boss, stress situation with family members, tax purpose, financial issues, 100,000 things that are running through your head while you should perform surgery, while you should perform really those cognitive movements in high extreme stress situations. So the next question would be, what do they have not in common? And that is something where you say, I understand why mental training is crucial and important. Because Michael Jordan was asked, what is a great athlete? What makes a great athlete? And his answer was, you have to accept failures to be a great athlete. And on the other hand, he said he missed at least 4,000 to 5,000 times the basket during his career. So that is something we should not have in common, because that is what our brain tells us in extreme stress situation. It could be completely blocked. So that's the reason why mental training is so crucial to realize blocking mechanism and then change it to creative one. So that is the reason why sometimes our brain is so blocked that we face the only tree on the street. So what we want to achieve is a high performance, is a great performance, is a perfect performance. And we have already have heard two presentations how we can achieve great performance. Because it is evident that a great and better performance is absolutely associated with our patients' better outcome. Less readmissions, less complications, etc. That's really a very great evidence we have. So we heard already that peer rating and feedback is absolutely crucial to improve our skill. So we have the possibility of virtual reality, of box training, and other modalities that we have heard already. But what I can tell you is that even if you are very good in your virtual reality, but if you are distracted, your score is dropping down significantly. That will mean your performance is influenced by distraction. And when we have a look on evidence, we have really a lot of studies that shows that box training, virtual training, which one is better. It's not that what I want to focus on. I want to focus on that your score, your performance, you can absolutely increase if you implement mental training in your everyday's practice. So what is the energetic signature? What is the action, how your brain works in anxiety, in stress situation, in distraction? And that we will come back to the high performance pyramid a little bit later on, where we say it is influenced how we are dealing with our physiology, how we are aware of our emotions and feelings, what we think, and of course, all of those will influence our behavior and at the end of the day, our performance. So it is crucial that we should be aware that distraction can affect our performance significantly, even if we believe that we can do everything completely subconsciously. So one of a very good example is live surgery, where the auditorium can directly interact with the surgeon who is performed on the live stage, and this paper is really greatly showing how different the patient's outcome is in between the same surgeon doing a live surgery with interaction with the audience, or the surgeon is doing the same procedure in his own environment. And those are really collected, high-ranked and high-named bariatric surgeons in this paper. So there are situations where you say, I have a moment where I'm absolutely distracted by the procedure itself. And not only you, if you have such a situation, the entire team can block the frontal lobe and react completely unlogical. So it is great to be prepared in such situations. So you all have those examples, how your brain is working when you do your first procedure, wonderful, as a resident, as a junior surgeon, until the boss or any other leading person is coming in and starting criticizing you. So your first very harmonic, wonderful procedure is getting disrupted and could really be in a not nice performance. I think everyone has examples of that. So to be really fully present and laser focused and full aware, you need to be aligned with your physical capacity. You need to be aligned that the emotional capacity, which is the awareness of your physical capacity, and also mental prepared, that you are able to perform your procedure in the best way. And how can we achieve that? And that is the last part where I want to focus on how can we implement mental training? How does it work in our everyday life? And we have beautiful examples. We developed those training modules in Hamburg at the European Surgical Institute and could publish really nicely the efficiency of the mental training. And it is beneficial, but it is more beneficial for expert surgeons. And that is really great to see in 10 randomized controlled trials that mental training is beneficial and experts might benefit and profit more than novice surgeons. So I already mentioned what this training could do. It could recognize blocking thought patterns and exchange to new constructive one. So how to do this? How to implement? Because everything starts with the definition of nodal points. That are points and parts of your procedure that are essential, that you have to go successfully through, and it doesn't allow any reduction of freedom actions. So that is quite important to understand before you start visualizing your procedure, that you define your nodal points of the procedure. And you can do this perfectly with your residents, with your junior surgeons, with those who you want to train, that you describe your procedure, what you need on instruments, what are the dangerous parts of this procedure. And you start your training with concentration, with meditation. And that is something you can learn within 1 week. There are several applications also for free on the App Store. So that is the reason that you can really rule out and exclude the distraction that you have in your mind. What is let's say those distractions that blocks your brain, financial issues with your boss, issues with your family. So before you start training, you should get really clean and clear out of all those disturbing and distracting facts in your brain. So then you are ready to do idiomotoric training, and idiomotoric training is something that I would like to describe a little bit. Idiomotoric training is visualization of your planned procedure in detail. And that is what you do with your hand, with your right hand, with your left hand. When you do your stitch, mentally you visualize the tissue in front of you that you will have, and you move your hand, you move practically your body. As we know from sport greatly, that athletes are doing this every time. And what you have seen here, before you start, whenever you have this stress situation, you are trained in meditation. You know how to get clear in your brain, and that's very often with breathing technology. So the practice, what you will do, starts with meditation, and very often you start focusing on your body. You don't judge whatever you feel. It could be a phrase, but however, everything starts with breathing and watch an object. So that is how you start. And your trainer, or let's say the one with whom you want to perform this mental procedure, is sitting either in front of you after having done your meditation, and then you visualize the planned procedure, either the full procedure or parts of the procedure, which usually makes more sense to save time. I give you an example of a, let's say, complex case that you can prepare, or that you prepare, because that is what you don't have every day. For instance, I give you an example. 2 years ago, I had to prepare for a patient that had a band erosion, splenic abscess, laparotomy, cholecystectomy because of cholecystitis. He was repaired by abdominal wall hernia. He had also a hiatal hernia. He had a rural Y gastric bypass, a weight regain, pouch trimming because of that. Then because of dumping syndromes, he had a reversal from a rural Y gastric bypass to a normal anatomy and a sleeve resection. He developed after that a leak. He got a stent. The stent was restented. It was a stent migration. So let's say a very complex case of a patient's history. And he came to my practice with following symptoms. He suffered from reflux, he suffered from dumping, and he suffered from weight regain. And after, of course, all the rules and regulations in preparing, we had decided to do a CDS, and that is where we started. The team, the entire team, sat together and described, first of all, the challenges. Then we described the nodal points of the procedure, which were, of course, safe laparoscopic access. We have to define parts of the procedures where you have always the possibility to step back and stop the surgery until you have really done the point of no return. So it is absolutely crucial when you have, let's say, those parts of the cases, you can do the mental training at any time when you say, I wanna do, for instance, the hiatal repair in a mental training way, where you see, I dissect with my right hand and keep the active blade of the energy away from delicate structures. I remove the tissue with my left hand and put a slight tension before, and so on and so on. So you describe what you have in your imagination. Then you close your defect in your visualization, and so on, until you will come most probably to the most delicate part, which will be then the dissection of the post-pyloric area, after having said that this patient had the cholecystectomy, cholecystitis. So that might be where you say, okay, I start lifting up with my left hand the post-pyloric area. I stay very close to the tissue, but I put a very short energy only on my tissue. So that is where you can do the procedure before you enter the operating room, in a way where you say, if I bluntly lift my duodenum up, I will see the duodenogastric artery. After I having identified that, which you see here, I will see the portal vein, which is also very close, etc., etc. So those parts of the procedure you can describe and you can visualize with your team. And of course, you can always have situation where say, what if? You always can say, okay, I stop my procedure and leave it up. I do not need to continue until I really start dissecting my post-pyloric area. So what you also can describe in a visualization. So for the sake of time, unfortunately, I will move forward where you say, until we close the defect of the post-stapling part, jejuno-jejunostomy, I will memorize what is essential to make and to do a high performance procedure. It is something where you really have to start with your physical capacity. That is something where you cannot operate when you are sick, you cannot operate when you are tired, etc. So it is also crucial that your emotional capacity is aligned with your mental capacity. So what you can learn and train is exactly that, to get rid of all disturbing and distracting parts during the procedure, so that you can really be open for your spiritual capacity. That provides you then the laser focused and full aware procedure. So yeah, thank you very much. I think I'm done with my short expression what mental training can do and how you can master it. Thank you very much.
Thank you very much, Dr. Miller. This is very insightful and important to have. So how do you see it incorporated within the steps of the training program?
It's part of a training program. So you know that I'm a trainer in the European Surgical Institute, in many other centers. What we do is a parallel structure. So of course you have your regular training program, and the regular training program, just to give you a short idea how I do it, is in 4 steps. When it comes to, I teach and train gastric bypass surgeries, the first that the resident, the junior, is assisting the procedure. After that, I will mention each and every step before I do it. The next step will be that the assistant is telling me which step, what shall I do before I do it. And the last part is that the junior surgeon is taking over, telling me what I have to, telling me what he will do before he's doing this, and that is not the full surgery; it's part of the surgery. For instance, we start with the enteroanastomosis always first, so that is my personal habit, and he's doing the enteroanastomosis, as I said, in these 4 steps. And when the junior surgeon is doing it in the same way, in the same speed, then he can move to the next step. And that is, interestingly, within 10 to 20 surgeries, he has the same skill practically that I have when you implement those strategies. It's a very fast way how you can master gastric bypass procedure, let's say in a routine patient, not in reduce or in super obese.
And maybe go also to the panel. As a trainer, how do you practice mental training and training the residents on it? Dr. Kell?
Well, I truly enjoyed that talk, Dr. Miller, and I take it that we do it subconsciously, but we haven't actually voiced it the way you've done it so succinctly in your presentation. And I agree, when we take a resident through an operation, we go through the steps very carefully. We have a plan of action from the time we start our operation to the end, and I think that's very important. And also, directing your fellow as to what steps they do, watch for things mishaps that can happen, and all that's all part of the mental training. And I think that was very beautifully presented. Thank you, Charlie.
Good.
Yes, and Dr. Higa, how do you manage, the stress points of the surgery? I know as a surgeon, you're stressed out that the patient does well, and you want your resident to be able to overcome a stressful situation, but you're stressed yourself. So how do you manage
for myself? I do a lot of
many.
yelling and screaming and stomping around. It usually takes the heat off of it, but truthfully, I do that at times, and very well. But the truth is, all those things that Charlie, that everyone really presented, we incorporate. We know that these are all important. The distractions and things like this, and we can debate whether or not we should listen to music in the operating room or have pagers and things, but that's part of life. So very well that at times, especially toward the end of the fellowship, I will create distractions, and I'll create events like giving the fellow a fired stapler. What are you going to do now? How are you going to get out of this problem? Or something is not working right, a piece of equipment. And that's part of the mental training as well, is if there's a situation, are you going to be able to troubleshoot it when no one else can? You can't always depend on a technician to tell you what to do, because that life isn't on the line, and then you're responsible. And so getting the trainees used to distraction, getting them used to dealing with unusual circumstances to the point where it just becomes routine, it takes some of the edge off of it, I think.
So that's those are all great points, and the issue is, how do we put it all together? We talked about deliberate practice, we talked about simulation, and making residents go into and practice simulation on complex procedures, as well as mental training. I take thoughts from Dr. Cao, and how do you do it in your residency practice?
So I think Charlie really did it very well. It's saying that when you train someone, there is the physical side of things, there's the emotional side of things, there's a mental side, and eventually you get to the top of the pyramid where spiritually you got it all together. And that's what we like to see in our trainees. We start them as a junior, you teach them step by step, they get more complicated operations to do, mishaps can happen, but at the end of the day, what you want them to do is to achieve an operation that has got as little complication as possible, hopefully no reoperations and no problems that they're going to present as a result of your operation to the emergency department or even to your department. So it's a pyramid that you actually train your trainees to work up on, so that when they get to the top, they can then take the place of a mentor and teach somebody else.
And let's just go to Hazem real quick and see how we did on the mental training part, and if you have anything to add.
Thank you, Ahmed. Dr. Miller, thank you for the nice presentation. So, as Dr. Miller has correctly quoted, mental training has been proved through trials to be effective in the training of experienced surgeons and trainees. It seems to be more useful in experienced surgeons than in trainees. However, it does have a role. To summarize what Dr. Miller had done, there's a paper published in 2016 in the American Journal of Surgery, and they talk about a curriculum, which is mental skills training curriculum, and they seem to have downsized it to 8 or 7 actually. They've got 7 modules that they go through it with the mental training. It starts at the teaching the trainee the science of attention and focus. Then they move on to goal setting, which is the nodal point that Dr. Miller had spoken about. Then they move on to train them to the activation management, which is the skills of relaxing both physically and mentally, and also the technique to be able to raise the energy level when fatigued. They talk about attention management. They talk about imaginary training, which is what Dr. Miller had kindly said, to be able to visualize and plan the surgery in your head through its various stages and nodal points. And they talk about refocusing strategies in the event of developing unexpected events, what to do and how to regain back the focus. Lastly was the preoperative mental routine. And this is exactly what Dr. Miller had said with the athletes. They've got their rituals before carrying on with their routine or their sport, similar to when Rafa Nadal serves the ball. He's always the same routine. And us surgeons subconsciously do the same before surgery. So other than that, I've got nothing to add. Thank you all very much.
Thank you very much, Hazem. And it's an interesting paper to look at from University of Indiana, and just for everybody to have a picture of a curriculum. And we always look for a curriculum, and it's very interesting. Now we have many comments and congratulations on a great webinar to Dr. Julian Varis and Dr. Miller, as well as Dr. Namiri. One question to Dr. Varis from Dr. Fadi Mustra in Michigan. Is instructor feedback within your platform variable, or is there a dependent methodology to having an instructor give feedback within the platform?
Thank you. That's a great question. For me, it is very critical that the trainer is trained to give feedback. So usually we do a train the trainers course. Usually these trainers have passed first the course that they are going to teach. So usually they do the basic advanced curriculum, and then they do a train the trainers course so that they can know how to give a feedback, what is a good feedback, how to enhance the performance of the trainee. So the answer is yes, we standardize these trainers. Also how to apply the assessments to get different or a better correlation inter-rater reliability. We usually standardize them evaluating dummy videos that are, these videos are all have a common goal to, and we know in advance the score that they should have. So these trainers will assess these videos and we will know the variability between their assessments.
Great points. And we have two great comments from two great surgeons as well. Dr. Hempens mentioned that one of the most important things is motivation and keeping an open mind. Even if you get the expert level, good example he quoted is Dr. Higa, and he switched from transmesocolic to anticolic, despite the fact that he was famous for retrocolic. And I'll go to Dr. Higa. And how do you evaluate change, and how do you evaluate there is something better, despite sometimes as surgeons we are stuck at what we do?
Yeah, I mean, this is exactly what was mentioned, is you have to accept failure, like Michael Jordan. I mean, now, not everyone's comfortable with this, and that's an individual choice. Not everybody can take the risks that some of us are willing to do for the sake of research, for sake of betterment, for just improving the process. But it's important to do so in a very controlled way. It's not just random, but in a very precise, after looking at the data. When I changed our technique, or the way I did it, is mostly because I could accept the fact that there's probably a 1 or 2 point improvement as far as the internal hernias, and that was enough to say, okay, I give in. This is better. But it's still good to know many different techniques, and I think what Jack said was very important. In a way, sometimes the biggest obstacle to us becoming better is our own ego, and that really has to be left at the door. And today, when we have such connectivity, I can't tell you what a comfort it is nowadays to go into an operating room knowing that I can call on any one of my colleagues, local or somewhere else, to ask questions about a particular problem. And you find as you get older, the collaboration is really the beauty of what we do. It's what really makes keeps us alive, makes it fun.
And Dr. Malfolby mentioned the importance of mental training, and he mentioned the mental training is very important to minimize complications, just like you said, Dr. Higa. Dr. Miller, how can mental training influence that change in behavior in surgeons to accommodate and incorporate better outcomes?
Most probably, if you do your surgery before you go into the operating room, you can challenge your trainee. You can give them tasks during he's describing the procedure in detail. You say, now you have a bleeding from the upper part of, let's say, the spleen, and how would you react? So you can create scenarios in a dry setting, in a face-to-face training setting, where you basically program your subconsciousness, as I mentioned, like this iceberg. The biggest part is subconsciously what to do if you have the situation, and it is something that I really want to emphasize. We should not accept failures. This is what should us differentiate from athletes. We should absolutely not accept, and that is the reason why we can, let's say, simulate those challenging situations mentally in visualization, in visualizing this particular part which could be dangerous.
And Dr. Cow, is there something along the way that made you change what you do, and how did you evaluate those outcomes prior to implementing change within the context of what we're talking about?
Sometimes as surgeons, we are very comfortable with what we do. We get taught a certain technique and we just keep repeating that same technique because we're comfortable. But what I found is that sometimes going to conferences and watching somebody else do something differently, you say, hey, that's something I never thought about. And that seems like a nice technique. And then what you do is you go back and you modify your technique based on something that you watched and thought that was better. And I think, watching somebody else do an operation and you pick on somebody's skills and say, I could improve on what I thought was a near perfect technique. You have to be open-minded. I think that's very important. Just being open-minded.
Lillian, absolutely. I give you the example how I developed the bypass in 2000. It was a combination of Jacques Himpens and Cadier's performing the gastric bypass. And I realized whenever I visited Jacques, he always had slightly modifications. He did always something a little bit different. So I think it is really crucial to not to sit in your bubble and operate and believe you are the best in the world. It's crucial to be open-minded, to see. When I saw first time the hands-on anastomosis from Kevin, I was breath taken away. And I say, wow, this is something you have to master. But before you go into a patient, you have to do it in an animal lab. You have to do it in a simulation until you feel really comfortable. And you will have the situation where you have no other possibilities than to do a hands-on anastomosis. And that is what makes, let's say, our society so strong. We have a very open mind to people coming into our hospital, coming into our department, sharing the experience. And then you can adopt slightly different parts of the technique. And again, if you do it in your mind, you really get aware that, yes, I will implement it in a safe way.
And with that, we have a question from Dr. Mahendra Lodha. Does Ifso have any plans to manage mentorship training programs? And we have the president with us. So
Well, I have to say, if there's a need for it, we'll definitely implement it.
definitely. And with that, before we conclude, I want to get everybody's opinion. So what should we recommend for trainers and trainees to do within this pandemic until life gets back to normal? Dr. Higa?
Well, I think, you know, it's an interesting time, isn't it? We never expected this, but it is here. And it's a tragedy that so many people have to lose their lives, but in a way, evolution is messy, it's dirty for things to change. And we know that medicine is headed in the wrong direction. We know that the way things are in the United States, around the world, it's not sustainable. We can't keep doing what we're doing. It's too expensive, it's not very good. Even the training process takes too long. It's broken. I think this gives us a time to throttle back, reevaluate, and look at things that what we're doing to the planet, for example. I mean, you can imagine right now the environment has never been cleaner, and because we're not doing so much traveling and we're staying at home and that sort of thing. I think it's a time really to take advantage of this and to change what we're doing, to incorporate you know, telemedicine, all these sort of things. And I know that's a very big part of what Lillian was wanted to do when she first started, and that's fantastic. So it's an opportunity, I think.
Dr. Miller?
Take advantage of this and to change what we're doing, to incorporate you know, telemedicine, all these sort of things.
I think your mic is off. We can't hear you.
Now we are so sensitized.
I think it's a poor connection.
Lillian, you should. I think Ifso can afford to get Dr. Miller some better internet connection.
It's really a problem that I cannot unmute several times. So, however, we as surgeons, we always, yeah,
Yeah. We should.
That's very strange. I have a very good one. So I have 100 megabits per second, but most probably people around me are blocking everything.
Yeah, maybe.
Maybe you're being overpowered.
Adversity doesn't occur just in the operating room, and how people how you deal with all this. This is just nothing compared to the operating room. Dr. Miller was nice. Charlie was nice enough. You know, early on, I visited him and you know, because I was trying to learn how to do bands and things. And he allowed me in his operating room. Like he said, the bariatric community has been very open to a lot of collaboration and things.
Julian, what do you think trainers or trainees should do?
I think, well, the first clear message from Dr. Nimeri is deliberate practice. We should try and focus to obtain and achieve deliberate practice. This means to get feedback from a teacher. So if you're lucky enough to get access to a training program and to perform a simulation, for example, this is a good time to do it. If you're not, what I would recommend in order to include Dr. Miller's recommendation is something that we usually do too, that is to gather all the videos you have about surgeries and edit it. If you edit videos, you will cut off the bad parts of the video, and that's a good learning. That's a way to prepare your mind for a surgery. You will learn the procedure, and there's so many videos nowadays, so let's take an advantage about media and about this pandemic itself. So I think there's some opportunities for trainees and for trainers. Please get involved with trainees.
Thank you, Julian. Those are very interesting points that you raised. Dr. Cal, final message.
I think practice makes perfect is a very good start. Trainees need to practice their technical skills, and that's how they can improve on it. In this pandemic, it is stressful, and therefore it builds on resistance and resilience, and they learn from all the mistakes that Dr. Higa have talked about. You know, the environment is much better now. You know, there's less traveling, there's less pollution. And we also learn that we can't rely on other countries to manufacture things, so we have to manufacture things in our own countries and be self-supportive and learn from others as well.
Definitely. Great points. And thank you all for being there. Thank you, Dr. Higa. Thank you, Dr. Cal. Thank you, Dr. Miller. Thank you, Dr. Barris and Dr. Namiri. Hazem in the background as well for being our fact checker behind the scenes. And hopefully we'll see you in 2 weeks where we're going to talk about restarting bariatric practice and what to do. And it'll be an interesting debate. So hopefully join us then. And if you missed this webinar, the recording will be on the YouTube channel. Spread the word for those who did not attend it. It's very interesting. And I'm gonna rewatch it again just to see the most interesting points in it as well. Thank you all.
Great talk.
Thank you, Matt. Thank you.
Thank you. Thank you very much.
Bye-bye.
Thank you.
Bye-bye.
Great opportunity.
Thank you.
Thank you, guys.
Okay.